wisdom, source of intelligence. We welcome you to this auspicious gathering, an august moment for the pursuit of knowledge that is offered for the glory of your name. We do not wish to ask you more than just you joining us today, but we look forward to your heavenly grace, to amplify the desire for truth, to look up for and become prudent to learning. Keep us grounded in your love and mercy, as we traverse a challenging path to keeping the inclination of understanding you and your most awe-inspiring creation. Be with us, O Lord, and descend your Spirit on us, to maintain an earnest desire for knowledge, truth, and understanding you, the guide of the wise, the stronghold of the learned. This we ask through Christ, our Lord. Amen.
Through the dreadful darkness, we shall lead the light and lead a path to wisdom. Our will to be our right. To those in pain and suffering, we shall hear a call.
Brothers and sisters, poor and the rich, we are the workers of the community. We are the doctors of PSMID.
Good evening, ladies and gentlemen. I'm Dr. Elaine Gunanan, and I am pleased to serve as your moderator for tonight's event. Just to emphasize some house rules, please make sure that you are muted to avoid distractions, and feel free to type in your questions in the chat box at any time. We will be opening up the session later on for your questions. Last week, infectious disease experts ably elucidated the efficacy and safety trial data results behind the COVID-19 vaccines. Today, we have in our midst eminent experts who will enlighten us this time on the principles in the equitable rollout of the COVID-19 vaccination program in our country. But before we begin, please lend your ears to our President, Dr. Mario Panaligan, for the welcome remarks.
Magandang gabi po sa kanilang lahat. And definitely, I am thanking God for this opportunity again for us to hear experts discuss a very important topic, which is mentioned, principles in equitable rollout of a COVID-19 vaccination program in the Philippines. Certainly, there's still lots of concerns on this particular vaccine as to whether they're going to be useful and how they're going to be given to all of us. Siyempre, may mga issues, bakit may nauna at bakit merong huli at bakit may nauna pa. So there are, of course, some issues as to how we can be fair, and certainly there are lots of questions. And I think we are very, very blessed to have renowned speakers and authorities to discuss this particular topic. And I welcome you all to this particular webinar session. Thank you very much.
Thank you, Dr. Panaligan. Now to formally introduce our roster of distinguished speakers. So I will introduce them based on in the order of their talk. So our first speaker, who will highlight the ethical issues in the COVID-19 vaccination program. We have with us the past president and advisor of the Philippine Society for Microbiology and Infectious Diseases, and the former chief of section of the infectious disease section of the University of Santo Tomas Hospital. She also has numerous handbooks of ethics to her name. She is our go-to person when it comes to ethics in medicine. So please welcome Dr. Rosario Angeles Tan Alora. She will be followed by an equally esteemed speaker who will highlight this time the equity issues in the COVID-19 vaccination program. She is a health social scientist, and I dare to say one of the prominent social scientists in our country. She's also a professor at the Department of Clinical Epidemiology, College of Medicine, University of the Philippines, Manila. She's also a member of the World Health Organization for Social Science Working Group on COVID-19 and the National Immunization Technical Advisory Group for COVID-19 vaccine. Please welcome Dr. Nina Castillo Carandang. Now, to provide us the principles in identifying priority groups in a COVID-19 vaccination program in the Philippines, we also have with us the Director of the Disease Prevention and Control Bureau of the Department of Health, Dr. Napoleon Arevalo. Now, let us start the ball rolling. May I now call on Dr. Angeles Tan Alora for our first lecture.
Okay, I will try to get my screen. Good evening, everybody. We're getting there. Thank you for coming and attending this lecture. I'm not getting my screen. Sorry.
Doctor, you can also, okay.
There, I have it now. Slideshow. Do you see it
Not yet po.
now? Not yet?
Hindi pa po.
Not yet po.
Bakit hindi? Escape. Zoom. Slideshow.
Doon po sa shares.
Share screen
Did you
po.
see the share screen po, Doctora?
Yeah.
The green button?
Pinress ko na yung shade screen. Sorry
It's okay.
talagang matigas ang ulo. I pressed na the share screen.
Apo.
I pressed it na.
Sige po.
Oh, ay bakit walang lumalabas?
Then click po niyo yung sa PowerPoint na lumabas.
Apo, click niyo po
Yeah.
yung box na
Yung box ng
nakasulat
PowerPoint.
PowerPoint. And then share po. There's a blue button on the right hand side na nakasulat po share.
What keeps coming out is the actual slide. Sorry.
Yan po. Nag-start na po.
Okay na.
Yes.
We're something
we can
po.
see your screen.
Isa pong part ng screen niyo yun.
But I can't see it.
Nawala po siya.
I put again share screen.
Apo.
Hmm.
Ang narito po yung Viber po niya. Ang lumabas.
So what do I do na lang now?
Yeah, yan po. Yan. Click that one po. Yan.
Yan.
Okay, very good.
Ayun.
The other one po, Doc.
Yung
Yan, that
po-
one.
Yeah,
Okay.
the other one.
Oh, what do I click now?
The other one pa po, Doc. Can you go
Which
down?
other
Yeah,
one?
that one.
Yeah, yan.
The red one. Yes.
Yes, that's it.
Okay, and
Then
then
slideshow
play
po.
po.
Yan, that's it.
Okay.
That's it, ma'am.
I'm on na.
Yes.
Po,
You
Doktora.
can see
Okay.
it now.
Sorry. Okay.
po, Doktora. Yeah.
Please understand I'm 85 years old.
It's
No
okay.
problem po.
It's okay po.
So we're looking at the principles and the equitable role of COVID-19. The media is full of vaccine news. The vaccine is coming to save the Philippines. The president, the Pope, the Queen of England has been vaccinated. And individuals ask, should I get the vaccine? Should I trust them? So the objective of this session is to highlight the ethical principles in the equitable rollback. And to help you answer the questions mainly of should I trust? Okay. We're a physician with some interest in bioethics. I am not a member of any group involved in the rollout. I am a member of the PSMID, and we are calling for transparency and equity. I am a candidate for a civil first priority, being a practitioner, so frontliner in a way, 85, diabetic with a pacemaker. This is an outline of what we will talk about. Okay. Equitable to mean fair and impartial. Roll out to mean officially introducing it. We assume that the COVID vaccine has benefits. Direct benefits to the person who is vaccinated against severe COVID. Indirect benefits to those who are not vaccinated because those vaccinated will not be vectors anymore of transferring to us, hopefully. But it has its risks. There may be side effects. They cost money, cost time, special facilities, and what will appear to come, at least initially, is limited and fragile. Another assumption is not everyone is eager to be vaccinated. And it is the government that regulates procurement and administration. Now, why is it important? The ethical considerations are important because there is a trust relationship between government and public, between physician and patient. And this obliges us to seek the best interest of the public and of the patient. Vaccination is part of this obligation because health is to one's best interest. So issues of political and economic criteria being considered more than scientific or moral criteria. Issues of political agenda being more important than social responsibility bother us because healthcare is a moral endeavor and that needs moral criteria. So what are the principles? The first principle, since we're talking equitable, is justice. Treat equals equally, treat unequals unequally, proportionate to their unequal qualities. So when you think vaccination, what is this quality that may make people unequal? Since vaccines prevent disease, the quality should be susceptibility to the disease and the consequences of getting the disease. So who will be hurt most? Who will die if they get the disease? Who will transmit it most if they get it? And who, if we lose them, will cause the most damage because they are essential for our social and health maintenance. Those who are most in need must be vaccinated first. And we must mitigate the inequities that bar the opportunity. So I am old, I may be vaccinated first, but I live far away from the centers that vaccinate. I am poor, I do not have the facilities to get there. That is an inequality, a social inequality that must be corrected because it bars my opportunity to get the vaccination. I don't trust the government. I will not be vaccinated. Again, I have to be taught how to trust the government so that I agree to be vaccinated. Because justice demands that I have the opportunity to be vaccinated. So how is this applied? So priority to the elderly at risk of complications or of death, priority to the frontliners who are at risk of getting because they are exposed so much and then transmitting because they expose others as much. And then to the health workers because if we lose them, they will cause the most damage to our healthcare system. The vulnerable and the distrustful must be reached. So there have to be facilities and procedures for informing, for motivating, for providing access. If you look at the world scene, then you notice the low-income nations must have access to the vaccines. Because the WHO report said, isn't it, that millions have been given already to the rich nations and the poor nations have nothing yet or very little. Okay. The second principle is stewardship, which means we have to take care of what has been given to us, responsibly manage it. And what has been given to us? The people, their welfare, their health. So we have to take care of people. We have to take care of ourselves as being one people, one person. And then we have to take care of the vaccine. That means we have to choose a vaccine that we can use efficiently. And we use it efficiently. So that relates to what we mean by social responsibility. That means orient to the common good. Think of the common good. That relates to solidarity, which means help each other. To utility, which means maximize benefit, minimize harm. And to transparency, which means what process is happening, what procedures are being followed, should be made public. You're trying to get trust, so you must be transparent. So how is this applied? Should a physician be vaccinated? Yes, because you have to protect yourself. You're a person. You have to protect your patients, your colleagues, your community. So based on stewardship, you have to be vaccinated. Two, the physician as an educator and role model should show what is responsible public health practice. Should a local leader choose which vaccine to use in his community? Again, yes, because he's the one who knows his community circumstances. He's the one who can tell which vaccine I can use, I have facilities for, and will meet the needs of my people. Now, we recognize that this is within reasonable limits. It's like the autonomy of a physician to practice the way he likes. Now, we have that autonomy, but it is within standards of care. So that's also here. The third principle is respect for person. And that means a person is rational, is autonomous, and should decide what is good for him or her. That is expressed in free and informed consent. In order to be able to do that, the person has to have truthful information. He has to know what a reasonable person would want to know. So in this situation, would I want to know the side effects, that I might die? Yes. So he has to be told that you have a less than 1% chance of getting a severe reaction and dying. I want to know, sino bang in charge? Because can I trust them? They have to be told. I want to know what is the process. Is FDA involved or is just their name involved? So that information has to be given. Okay? And then I have to be free to act. I cannot be coerced by the barangay leader, by the head of the hospital, forced injury. So how it is applied? Can a person refuse to be vaccinated? Yes, again, provided he was adequately informed and freely chooses to refuse, he can refuse. We have some scrupulous people who say, yung vaccine galing sa embryo yan na na-abort. So I will conscience object. Actually, they're misinformed. But presuming they are correctly informed, they can object and they can refuse. And we have to respect that. Now, what should be done by a healthcare institution when a physician refuses to be vaccinated? Kunyari, I'm part of your staff. and I don't want to be vaccinated. Well, first you find out why. And after you find out why, maybe it's justified. I refuse to be vaccinated because every time I got that flu vaccine, I had severe reactions na ICU ako. So that's justified. But you as the institution can also limit that person from staff and patient exposure. You can limit him from direct patient contact. And you can be more strict in whatever preventive practices he follows. Should a person be required to buy one and donate one? Sorry, that's wrong. No strict preventive practices. No, you cannot. You cannot force me to donate. That's coercion. It violates free and informed consent. Okay. So what is the leader? Whether you're in the government or private, what is your role? You have to establish a body of experts. Don't think you know everything. So you get the experts to help you. Let them make a policy for the procurement, allocation, and administration of the vaccine. And any kind of policy has to be justifiable. It must consider the science and the ethics more than the politics and the economy, so that it is effective and it is fair. It must be plausible. Kailangan gawin within our context. Tropical country, maraming islands. And it must be in concert with the other policies. And then I repeat, it must be transparent. And transparent in the sense that the information must be simple and understandable. Huwag niyo akong bigyan ng highfalutin explanations na hindi ko naman maiintindihan. So that it becomes acceptable to all the stakeholders. You have to explain why. You see, as an ordinary citizen, I may disagree with you, but if I understand why you're doing it, then I may accept and agree to be a good citizen. But if I don't even understand why, I will absolutely refuse. And it must be consistently applied. One message followed by everybody. I don't have to explain that. And the body has to be accountable. Now, the leader also must develop the public trust. And how? By communicating, I said, in understandable knowledge, by engaging, listening. What is your problem? What do you not understand? And by modeling. What about you as a physician? What is your role? First, you have to recognize the situation and the ethical implications. Then you have to be a team player. Let's act together. Huwag iba-ibang message. Kailangan one message. Vaccination is good. Okay, tama na. And use that. Educate. Correct the misinformation. Correct the hesitation. As I mentioned, listen, understand, give correct advice, engage, and act. Then even if you're a physician, you have your limits. Not all of us understand all the intricacies of vaccine analysis and vaccine. So let the FDA do their thing. We recognize they know what they're doing. So let them. And help implement the policy. So when you start vaccinating, when you have adverse effects, report. Because pharmacovigilance is very important. So be it member of the team, you report. And always I say, role model. As physicians, stay healthy, get vaccinated, and champion preventive measures. Now, what about the ordinary citizen? Be informed. Please listen to reliable sources. Very often, the media is hard to, kasi they look for publicity. So learn to discern. Avoid fake news, avoid misinformation, disinformation. And then once you're informed, act responsibly. So you decide, based on this correct information, should I be vaccinated or not? Yes, then go. No, then stop. But always promote all the preventive measures against COVID-19. So tuloy pa rin yung mask, distancing, disinfection, washing of the hands. And then do not meddle in issues you don't know about. Napakarami nagsasawsaw. Just listen to the Senate hearings. Parang lahat sila eksperto na sa vaccine. Huwag ka naman mag-black market. Because you cannot profit from the suffering of others. And pray. Pray for leaders and followers who will see clearly, who will choose well, and who will act right. Summary, a vaccination program should follow the principles of justice, stewardship, and respect for person. It must be contextualized, put it in our area, what we have, transparent and consistent. Priority should be for those in need, and efforts should be directed at reaching them. Goal should always be for the common good and the efficient use of the vaccine. Respect for individual dignity and right cannot be overlooked. And the challenge of the vaccination rollout should be faced by all of us, striving to have a community that is humanely compassionate to the vulnerable. Thank you. That's it.
Thank you very much, Dr. Alora. So that was a very engaging talk. And that's a challenge for us physicians to really vaccinate ourselves and encourage, especially our patients, to vaccinate themselves as well. Now we proceed with Dr. Nina Karandang to give us this time the equity issues in terms of this vaccination program. Ma'am Nina.
Thank you, Dr. Elaine. Thank you, Dr. Alora, for that wonderful sharing po. No? It's a big challenge for all of us. I am happy I am not a physician. Do you already see my slide, Elaine?
Yes,
Yes.
ma'am. Yes.
Okay. Magandang gabi po sa lahat. It's an honor to be invited by PCP and PISMID. How can I say no to two friends who had these two organizations, no? So Dr. Panaligan and Dr. Alejandria. So my task today is to bring out the other side of COVID and not necessarily the most medical side. And I've decided to entitle my remarks today as Leaving No One Behind, the equity issues in a COVID-19 vaccination program. Context matters, as Dr. Alora eloquently shared. We need to watch out for bias. We are human, therefore we are biased. And what is my bias? I am Nina Castillo Carandang and I'm proud to be a Filipino. This is part of my standard presentation wherever I go, whatever topic it is. I almost always include also a quote from my late nanay, national scientist Helia Tagumpay Castillo, and she said it very well when she talked about science, equity, and ethics. And let me quote, I've always believed that when the best science and scientists are devoted to the problems of those who have less in life, that is equity and ethics at its best. If science is serve a human purpose, what better human purpose is there? Some definitions: health equity. The U.S. Centers for Disease Control, National Center for Chronic Disease Prevention, and Health Promotion says that health equity is achieved when every person has the opportunity to attain his or her full health potential. When no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. The World Health Organization has a similar definition. when they say that health equity is present when there is absence of avoidable or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically. How about the opposite? What are health inequities? Again, from CDC, these are reflected in differences in length of life, quality of life, rates of disease, disability, and death, and the severity of disease and the access to treatment. And the World Health Organization says that it's more than just inequality with respect to health determinants, access to resources needed to improve and maintain health or health outcomes. And it entails a failure to avoid or overcome inequalities that infringe on fairness and human rights norms. As we all know, we are in the midst of the COVID-19 pandemic. But let me take you back to 1987, quoting the late Dr. Jonathan Mann, who was then the director of the Special Program on AIDS of WHO, when he spoke at the General Assembly of the UN in October 1987. He said we have three distinct yet intertwined global epidemics. The first epidemic now, and I'm paraphrasing him, is the viral infection itself of SARS-CoV-2. The second epidemic, inexorably following the first, is the epidemic of the disease COVID-19. The third epidemic is the social, cultural, economic, and political reactions to COVID-19. It is the third epidemic, the social, cultural, economic, and political reactions to COVID-19 worldwide, and as central to the COVID-19 challenge as the disease itself. Let me quote from Bridget Rowerder of the Institute of Development Studies in the UK. She did a study in September on the social impacts and responses related to COVID-19 in low and middle income countries. COVID-19 and responses to it have triggered a global crisis that extends beyond health impacts to all aspects of life. Impacts are harshest for those groups who were already marginalized and excluded before the crisis, and pre-existing inequalities are being exacerbated and deepened. So she talks about poverty, vulnerability, social policy, gender equality, social protection, empowerment, and accountability. This is a summary infographic of what Ms. Rowerder was talking about. So you have marginalized groups, a lack of data, which exacerbates inclusion, marginalized voices not heard, there's no social protection, women and girls are most affected, and the poor are becoming even poorer. Let me go through each one of them. So the poor and near poor are the risks of extreme poverty. Those who are very rich were able to bounce back in about 9 to 10 months. According to Oxfam today, and this is not part of Ms. Rowerder's talk, is we actually have the inequality virus, which sprung up due to the length of the pandemic and the lack of resources for those who are the poorest of the poor. For those of rich, nothing seems to have changed. So the inequality virus, and not only the COVID-19 epidemic and the SARS-CoV-2 virus. Marginalized groups most affected, they have already existing inequalities which were exposed and worsened by COVID-19. So for older people, for migrants, for forcibly displaced persons, for children, for young people, for LGBTQI people, for people with disabilities, for people in the informal sector, they have been badly hit by COVID-19. Women and girls are also most affected. I was listening to the news today, and it was very sad that the cases of online sexual exploitation of women and children has increased in the lockdown. This is an example of the social impact of COVID-19, which nobody wants to talk about. Whatever gains we have for gender equality have been eroded tremendously by COVID-19. The lack of social protection, according to the estimates, 55% of the world have no or inadequate social protection to protect from COVID-19 shocks. And it doesn't help if agencies such as PhilHealth, who are entrusted to take care of our social protection, don't seem to be doing a very fantastic job of guarding our interest. The marginalized voices are not heard. So the spaces in which marginalized groups can be heard are being closed. There's very little room now for productive, polite, respectful dialogue. People are up in arms. People are upset. And this even silences further those who are already marginalized from the start. So that was the social impact. And I would say that our current state of being is being unnormal. I refuse to use the term new normal because if we haven't learned from the experiences we've had during the pandemic, then we probably should go back again in the middle of the pandemic. If there is continuous injustice, hunger, poverty, malnutrition, abuse, and militarization of our response to COVID, then we don't transition to building back towards a better everyday. Why should we settle for the new normal if it is just a continuation of the abuses and the injustices we have today? Let us aim higher to build back towards a better everyday. The United Nations Development Program put out the Human Development Report for 2020. And the theme of their report was the next frontier, human development and the Anthropocene. And I borrow their particular framework here, where they say that planetary and social imbalances reinforce each other. So if we want to heal as one, we also have to heal our planet, because their risks, their shocks, their inequalities, and their pressures all intertwined with planetary imbalances and social imbalances. We cannot heal as one, as a human race, unless we also heal human nature. Quoting from the American Public Health Association in 2020, they said that everyone should have a fair and just opportunity to achieve good health and well-being. The strength of a public health system rests on its capacity to effectively deliver the 10 essential public health services. And let me quote again from them. They said, we need to protect and promote the health of all people in all communities. So if we look at this particular figure, it starts with assessment. We need to assess and monitor population health. We need to investigate, diagnose, and address health hazard and root causes. We need to go into policy development, and we start by communicating effectively to inform and educate, which Dr. Laura talked about also. We need to strengthen and support and mobilize communities and partnerships. We need to create, champion, and implement policies, plans, and laws. We need to utilize legal and regulatory actions, enable equitable access, build a diverse and skilled workforce, improve and innovate through evaluation, research, and quality improvement. And we need to build and maintain a strong organizational infrastructure for public health. This is the only way that we can achieve equity in health. In June 2020, the National Academy of Science and Technology invited me and Dr. Michael Tan to give a webinar in the middle of the coronavirus. And I entitled my talk, This Thing Called Corona. They came up with an infographic which summed up my argument in June, which hasn't changed. Policies for COVID-19 should be based on transdisciplinary and evidence-based science and good public health, sociocultural and behavioral realities, working together and communicating with each other are integral to a holistic response to the challenges of the pandemic. The so-called new normal is not normal. We need to pivot our responses, our priorities, policies, interventions, actions, and behaviors so that we can transition to what hopefully will be a better everyday in a just and humane society. Health is a fundamental human right. Let us not forget it. This is what we were endowed with. People and groups who experience health inequities lack power, whether it be political, social, and economic. Interventions such as vaccination programs need to be effective and sustainable. Access to the vaccine alone is insufficient. We need systemic changes, policy reform, changes in economic or social relationships. These are all imperative to help empower marginalized groups and ensure that no one is left behind. Maraming salamat po.
Thank you, Professor Karandang, Mamina, for that engaging talk as always. Yeah, I guess this equity issues, it's rarely taught in our medical school, so it's good that we can have this session. Okay, so both the ethics and the equity in terms of vaccination. Unfortunately, Dr. Napoleon Arevalo sends his apologies. He won't be able to make it. He's in the midst of an emergency meeting.
Wait. Elaine?
Is he
Elaine?
here? Yes.
He's already there. Nakahabol siya.
Okay.
Ah.
Oh, sorry. Oh, that's good. That's good. So we have Dr. Napoleon Arevalo. So that's good. So we proceed with our third talk this time after listening to the ethics and equity of the COVID-19 vaccination program. We now hear the principles that was utilized for the priority list for our own COVID-19 vaccination program. So you may have the floor, Dr. Arevalo.
Okay, maraming salamat po, Ma'am Elaine, and I am grateful that the DOH, this is Prevention and Control Bureau, is grateful for having been invited to this webinar so that we can provide information not only to specific groups of population that have stake on the COVID-19 vaccination, but to specialty groups as well that can be our multipliers in creating a greater demand for the vaccine. And we're grateful to your group that we were invited to this webinar. So I'd like to have my first slide, please. Next, please. So I'll be focusing on the determining the priority population, and this is actually based on the guiding principles as lifted also from the WHO SAGE, and that these are very basic. Actually, the principles of equity has been articulated already by Dr. Nina, but actually the guiding principles in the prioritization of our eligible population are as follows. Una, yung human well-being, and this is self-explanatory that where health, social, and economic security, civil liberties of all citizens and individuals are protected and promoted. Reciprocity is one guiding principle that we are having a greater focus on, because in this vaccination rollout, we consider the individuals and groups who have greater burden in the COVID-19 pandemic response and have a higher significant risks brought by the responsibilities and roles shall be given greater priority. So alam na po natin why the health workers are being prioritized, while some sector of the society or the government are being prioritized, and the sector or segment of society are being prioritized. So in the reciprocity, we take responsibility that the health system is not overwhelmed. We preserve our health workers. That is why we prioritize the health workers and some special segment of the population. For equal respect, where all human beings are treated equally and their interests are considered with equal moral consideration. That is why we in the NITAG we have invited an array of specialists to include Ma'am Nina for us to be able to have sound recommendation in terms of the prioritization considering equal respect. The national equity, where equity in vaccine access is assured nationally, and those with greater burden of COVID-19 pandemic are prioritized. This national equity also is an amplification of the principle of reciprocity. And last but not the least, where decisions are made through transparent processes based on shared values and scientific evidence. It's why we have the different expert panel. We have the vaccine expert panel. We have the NITAG. We also have the NAFIC for the adverse events, and we have the HTAC for cost efficiency. These are independent bodies which are composed of experts that are providing advisory to the vaccine cluster and to the Department of Health for us to be able to select and decide on what vaccines are to be accessed by the country. And all these processes are transparent, and that is based on shared values. And of course, we have to consider scientific evidence that is being provided to us by the scientific community, not only locally, but likewise internationally. So these are our prioritization, and this priority eligible group A has been identified, and of course in the prioritization, while we consider the guiding principles, we set goals, for us to be able to have these goals achieved, and this also helped us identify the priority eligible group A. And the primary goal in the prioritization is for us to directly reduce morbidity and mortality secondary to COVID-19 and maintain most of our critical essential services. While the secondary goals consist of for us to be able to substantially control transmission and minimize disruption of social, economic, and security functions. And the tertiary goal is that for us to be able to resume to a near normal circumstance, near normal lives. So dito po makikita natin sa priority eligible group A, based on the guiding principles and our goals. Una dito ang ating frontline health workers, which is about 1.7 million, and is consisting of it consists of the following workers, the public and private health facility health workers, or workers that are in the hospitals, in the treatment and rehabilitation centers, in the temporary treatment and monitoring facilities. Also, the health workers in the public health that would compose all personnel at the rural health units, the health offices, from the provincial health offices, the DOH provincial health offices, the regional offices of DOH or the Centers for Health Development, and the central office field workers who might also be exposed to the disease. And we identified the LG contact tracers, which were hired by DILG, about 50,000 of them. And we also consider the barangay health workers, including the members of the barangay health emergency response teams, because they are our liaisons and our navigators at the community level. Example of this, when we have isolated families or identified exposed individuals in their homes, then our barangay health workers are the one monitoring, as well as the one who are navigating these patients or would-be patients to health facilities if they need to be referred. Then, of course, the other non-national government agencies like the DSWD, the DepEd, the DILG, the BJMP, and the Bureau of Corrections, because these agencies have their own infirmaries and hospitals, and they have their frontline workers. Example of this, the DSWD, or the social workers providing social amelioration to our citizens. The DepEd has their health and nutrition personnel composed of doctors, nurses, and dentists. The BJMP and the Bureau of Corrections have their infirmaries, and they are also manning the closed institutions, just like the SWD, that if there's a fear that if we bring the infection to these closed facilities, then there might be problem on mass morbidity and probably mortality. So 1.7 million eligible population from the frontline health workers, which is about 1.6% of the Philippine population. The indigent senior citizens is about 3.7%. The remaining senior citizens, this is composed of 5.7 million. The remaining indigent population at 12.9 million, about 12% of the Philippine population, and the uniformed personnel, the PNP, the AFP, the PCGB, Bureau of Fire, and the CAFGU, because they are the ones in charge of our safety and security. And during the lockdowns, during our general modified general quarantine, they are the ones doing checks on the entry and exit in a municipality and a city or in a region. So a total of 24.6 million, or roughly 25 million of the priority eligible group A, which is about 23% of the Philippine population. So this is the definition of our enumerated eligible population. For the frontline health workers, these are all health workers from the private and public sector currently on active practice or service, regardless of their status of employment, whether they are permanent, contractual, or job order employees or staff. So ito po yung ating nasa aktibong panunungkulan. Perhaps we have health workers, but they are not employed at the moment, and they are their homes, probably doing some other business at home rather than employed in a health facility. So under which, in the public and private health facilities, the health workers who are all those who are working in medical centers, hospitals, clinics, the TTMFs, the TRCs, and those are assigned in special areas like triage, the OPDs, the ERs, wards, ICUs, ORs, and DRs, laboratory, radiologic, and pathology areas, rehab units, among others. And inclusion in this category are those who are assigned as part of the disinfection or decontamination teams. Ito yung ating mga utility, ito yung ating mga janitor, the medical social workers, and security guards of the above-mentioned facilities, because they are also considered as frontliners. So security guards are the ones manning our entries and exit, starting from the gates and entry to our health facilities. The public health workers, they are defined as all health workers in the public health sector who are providing direct health services. And included are all employees in the public primary care facilities like RHUs, CHOs, whether they are LGU hired or DOH deployed or hired. And those health workers are employed or detailed in provincial health offices, centers for health development, the Department of Health Central Office and its attached agencies, but they are also being qualified as field workers of the Department of Health, who might be in charge for monitoring the vaccination progress, who are part of the rapid response teams during adverse events following immunization, and those who are providing supportive supervision to our vaccination sites. Also, the LGU designated or deployed hard contact tracers, which are actually via the DILG. But there should be some form of validation, like that of documents stating deployment, designation of government employees as contact tracers. This might be executive orders of the local executives, resolutions from the Sangguniang Bayan or Panlalawigan or Panglungsod, and or an ordinance stating that they are part of the hard contact tracers of the DILG or the LGUs. And then we have the barangay health workers, including the barangay health emergency response team. So meaning all barangay health workers in active service. Meron po kasi tayong mga barangay health workers who have retired, baka sila ay mga 60 to 65 years old, that can be covered as part of the senior citizen sector. And all active members of the BHERTs, but also like the LGU hard or the LG hard contact tracers, should also be validated by documents stating that they are part of the barangay health emergency response teams. These are not limited to BHWs, but likewise might include the barangay tanod or barangay council members or volunteers of the community. For the other NGAs, like that of the Department of Social Welfare and Development and its regional and local counterparts, those employees manning closed-setting facilities and long-term care facilities. Example nito po, yung kanilang mga orphanages, yung kanilang home for the aged or nursing homes, the women's crisis centers, and the social workers providing social amelioration and social services in the community, because they are likewise exposed. Ang ating worry kasi dito sa ating social workers or house parents or the ones who are in charge of closed setting facilities, kung ito ay matatanda na, baka mabilis na mahawaan coming or the focus of infection would be the workers, then we might be having problems on the transmission, the fast transmission from amongst the elderly or amongst the children in the facilities, and we'll be having problems. Of course, I've already stipulated the Department of Education. They have their health and nutrition personnel. The Department of Interior and Local Government, I already have articulated this. The BJMP, and these are the employees and health workers assigned in direct contact with persons deprived of liberty, such as jail officers, wardens, and guards. And these offices have their own OPDs or infirmaries that are manned by frontliners. And of course, the same as with that of the Bureau of Correction. For the indigent senior citizens and the remaining senior citizens, these are all indigent senior citizens as registered and determined by the DSWD. So ito po ay may listahan po nito, and even our local governments have a list of senior citizens in their respective areas, at ito ay may mga organisasyon kung saan makakakuha tayo ng listahan that we can base our number of senior citizens, both the indigent ones and those who are not. So ito ay determined by the DSWD at ng OSCA. And also the remaining indigent population, these are the indigent population as determined by the DSWD. Meron din itong we say we have the listahanan or the National Household Targeting Survey, which are the basis of this group of population, and even the local governments have their list also of this segment of the population. And last but not the least, the uniformed personnel, those enlisted who are in active service under the AFP, the PNP, the Philippine Coast Guard, the BFP, the CAFGO, the Bucor, the remaining personnel of the Bucor, and the BJMP. So ito po ay kasali sila dito, and there are also, if you have heard announcements or pronouncements that those who are reservists and the families of these uniformed personnel, it is we will raise this to the NITAG because, of course, with the limited number or quantity of the vaccines that will be delivered to the country in tranches, then we still have to prioritize those who are of great burden in terms of responding to the pandemic. So titignan din po natin to at i-raise natin sa ating NITAG because we would like the recommendations not only on we started with recommendations on the pregnant and lactating mothers. We are also consulting them on the cap for the elderly population, hanggang ilang taon ba ang pwedeng bakunahan natin. Then of course, immunocompromised, and also setting criteria for the priority geographical areas. But of course, we consider first the sectoral, and then with a limited quantity of vaccines that will be coming, then the NITAG has at least set criteria on how to prioritize geographically the first tranches of vaccine. So tinitingnan dito nila yung disease burden as well as mortality rates. So for the priority group category or priority group B, na itaas natin yung teachers and the school workers, because we say that if we would want to have face-to-face learning modality, then we also have to prioritize the segment and the other government workers, yung ating mga frontline workers in government that are also identified to be under priority B, and this is in coordination with the Civil Service Commission. Both have at least 1.7 and 1.1 and 1.7 million population respectively, comprising about 0.95% and 1.6% of the Philippine population. Then other essential workers outside health, education, social welfare sectors that would be included, like those working in agriculture, food industry, transportation, tourism, manufacturing, construction, among others. We are already connecting with DOLE and with DTI for us to identify these essential workers, and we set criteria kasi meron din silang sino ba talaga yung uunahin natin from among these workers, no? Yung into the production, into the transport, no? So kailangan din natin ma-identify yung essential workers outside health. So tinitingnan din natin dito yung micro-entrep, yung ating mga informal workers, like those engaged in tricycles, yung mga ano ito, pitoda, batoda, yung mga ito, yung mga vendors natin sa gilid-gilid ng ating or sa sidewalk, yung ating mga informal vendors. And we hope that with the list from the DSWD 4Ps, then we will not be duplicating our master list for these essential workers. Of course, the socio-demographic groups that are significantly at high risk, other than the senior citizens and the IPs. Example of these are the persons deprived of liberty, the PWDs, and the Filipinos living in high-density areas. You can just imagine if somebody from the jail guards brought, or somebody from the house parents brought the infection to to the persons deprived of liberty, or to the senior citizens in our elderly homes, or to the children in our child minding center. So nakakatakot na madala natin ito doon. So also kung makikita natin, no, I had the chance to go to Recto for some errand, and I think the side on that side of the under the LRT, yung parang densely populated doon na yung mga bahay nila dikit-dikit at several parang mga informal setters, so we have to also consider them. And of course, the indigenous peoples. We are also considering overseas Filipino workers because this segment might be required by their employers abroad before reporting to work or going abroad. They are to have that vaccination. So tinitignan din natin yung parang reciprocity. This is outside the principle ng reciprocity na sinabi natin, that there are countries whose the Filipino overseas workers were vaccinated by their country. We are taking a look at also the OFWs based in the Philippines, no? Meron din tayong mga manggagawang galing sa ibang bansa. So kung binabakunahan yung ating OFWs ng where they are working, then we also need recommendations from our experts. And then the other remaining workforce, and the total eligible population in the Group B is about 10.5 million, which is about 10% of the population. So we really need to, sabi ni Ma'am Nina kanina while wrapping up, walang maiiwanan. So there would be no one left behind for the vaccination. So tinitingnan natin kung ang sinasabi that we will be having the quantity for the 70 million Filipinos by 2021 in different or in varying tranches or in different phases, then lahat mababakunahan. Of course, yung mga under 18 years old, no? Kasi sila ay about 35 to 36% of the population. So until after recommendations from our experts kung sila na ay babakunahan in the coming years. Next. Next, please. So, of course, since we have planned the vaccination program into phases, so baka may spill over tayo sa 2022, but that depends on the number or the quantity of doses of the different vaccines that will be available in the Philippines. So sinasabi natin lahat mababakunahan, depende yan sa pagdating ng ating supply. Next, please. Okay, that was my last slide, and I'm giving back the floor to our moderator. Maraming salamat po.
Thank you once again, Dr. Arevalo. And thank you for providing us with a detailed list of the priority individuals, and also for gracing our event despite your hectic schedule. We now open the floor. So we have some questions in the Q&A segment and chat box. So may I ask Dr. Arevalo, Professor Carandang, and Professor Alora to be with us for the open forum. Actually, I looked at some of the questions. So some of the questions I will address to Dr. Arevalo. So this entails a more detailed, they want to know a more detailed list of who the priority patients are with regards to those in the healthcare frontline setting. So some were asking, what about those who are just doing outpatient private clinics? Are they included?
Yeah, there are actually there are questions on uh, the Manila International Airport and answer those questions. One, as we have said, all health workers in public and private are included in the allocation as long as they will be enumerated by the respective local government. So what is important is for these private facilities, yung mga primary care centers natin, and our private hospitals be coordinating with the local government units because they will be doing the master listing of the eligible population. So if there are frontline health workers, pwede sa primary care center, mga dialysis center, or yung mga ano natin, yung mga parang ano tawag dito, yung mga OPDs natin, and those surgical clinics, they are included in our eligible population. What they have to do is to coordinate well with the local government where their facilities are located. Yung sa NIA po, ng mga health workers, you have to coordinate with the Bureau of Quarantine because the Bureau of Quarantine is included in our priority population or eligible population, as they are part of the Department of Health, considered as frontliners. So yung mga health workers dito po sa MIA, makipag-coordinate lang sa ating BOQ so that they can also be enumerated.
So malamang kasali po dito yung mga medical clerks and interns?
Yeah, actually pinag-usapan na yan, but the medical clerks and interns now are not required to report to hospitals as of now. But if this segment of our students would be required or tapped to become volunteers of the vaccination centers, then they ought to be in the list.
Okay. So if they're already doing their duties, most likely. No? So there's also some questions regarding the non-medical workers inside the hospital. For example, yung mga nasa cashier, nasa billing, mga
actually, yes po. For the COVID hospitals, the one who are exclusive for attending to COVID patients, lahat sila babakunahan, no? And in areas or in hospitals that are not designated as COVID hospitals, we prioritize first those who are attending to the COVID patients. But definitely the hospital staff, whether they are indirectly serving or providing services to our patients, they should be enumerated as part of the hospital personnel because we will be allocating supply to the hospital, and should there be limited quantity on the first tranches, then they have to prioritize again to the most vulnerable or at-risk population. So baka mauna yung mga nasa COVID ward, yung mga nasa triage natin, nasa ICU, bago yung ating mga admin staff, no, if there would be limited supply in the first few tranches of our vaccine.
So by the way, is this list available in the website? Some people are asking.
We already have cascaded the capacity building to our public and private health facilities, to our local government, and to our private counterpart. There is a system of registration. So meron po tayong sistema ng registration wherein both public and private facilities and the local government will initiate the enumeration of this eligible population, and they will be provided with a unique identifier using their PhilHealth numbers or employee number. Actually, there are local governments who have already their unique identifier, and they should be now master listing their employees in the hospitals, both public and private, because we will be needing this, for for us to be able to rationally allocate the supply that will be coming to the Philippines. So, meron pong sistema, nag-cascade na kami nung how we will go about master listing and application that the DICT, the Knowledge Management Information System, and the Epidemiology Bureau formulated as to have that application used by our health facilities and the local governments and the private sector in enumerating their priority population.
For this, can they ask for a copy of this priority list?
Yes
The
po.
one that you,
Yes po.
okay. So
This has been presented already to the Senate, to the Congress, and the National Deployment and Vaccination Plan has been will be widely circulated via memo coming from the Department of Interior and Local Governments,
So
and we
this
have
will be
already shared this
to everyone.
so much of our counterparts.
So the next question I'll address to, let's deal with the ethical part for this. There were some suggestions to use non-medical government workers, so here particularly public school teachers, who will be trained to inject the COVID vaccine. So I'll address this to Dr. Alora. Will there be any ethical problems
Yeah,
with it?
the issue there is their training going to make them competent? Kasi pwede matrain nga, hindi naman natuto.
Okay.
So
So
what
as
is
long-
required? Yeah, is they are competent and they are informed of the risk and they agree to do it.
Okay, so as long as they are trained
Yes.
properly.
Dr.
As long
Elaine,
as
can
they
I
learn.
just add?
Yes.
We had a town hall with the Philippine Medical Association, Philippine Nurses Association, Philippine Pharmacists Association, and then this Saturday with the midwives groups. No? The pharmacists under the pharmacy law
Yes.
are actually authorized to vaccinate, but they haven't taken up that role yet. So like what Dr. Alora is saying, they have some training, but they don't yet have that level of competence and confidence to do it. Hopefully that we will be able to tap into their group for more training, to build up skills, to build up knowledge, and also confidence to do it. And let me just share that we did an entry and exit poll for each of the town halls. I designed that entry and exit poll. At the beginning of the town hall, whether it was a doctors, nurses, pharmacists, there was actually quite a lot of hesitation. So they were asked if a COVID-19 vaccine were available, it's passed through the FDA, it's safe, efficacious, would you be willing to be vaccinated? The PISMID colleagues in their survey, which I designed for them, about 93% said yes, they would. But the other physicians expressed hesitance. Same for the nurses, and the lowest was for the pharmacists. After 3 hours for each town hall has vaccinology, immunology, deployment, social science aspects, then the numbers do change. So they go up in terms of willingness to be vaccinated and also willingness to be a vaccinator. I included this question for the pharmacist. So it seems like if we do have better information and we refuse to be uninformed or underinformed or misinformed, then we can do better with our task in the healthcare sector. We can also do better in convincing patients and communities and families, because we must recognize that the communities and patients look up to the healthcare workers, such as the physicians attending this forum, for advice. So what is your advice? And like Dr. Alora said, if you can't advise for them to be vaccinated, how you can actually convince them? So in the Saturday forum with the pharmacist, Dr. Montoya of PCHRD was very candid. And he said, ayoko pang mamatay. Ke 50% yan, ke 75, 90%. kukunin ko na kung anong bakuna ang nandyan, mas mabuti na yan kesa sa walang bakuna. So ang quotable quote ni Jaime Montoya ay, ayoko pang mamatay. Yun po nung Sabado po yon. He's a former president also of PeaceMade. Salamat, Elaine.
Okay, thank you.
Ma'am Elaine, if I
Yes.
can have a rejoinder to what
Yes.
Ma'am Nina said
Yes.
and Dr. Laura has said, we are enjoining the academe, the teachers to be part of the vaccination team, but we would like them to be trained perhaps on health education so that they can be part of the health education component during the vaccination proper. But if they already have been tapped by our local governments, then probably they can start as our multipliers in terms of demand generation. Pero kailangan yung communication handle na maayos, na train sila so that they can help us out in increasing demand for the vaccine. And pwede po sila, pero I guess the actual inoculation may be limited to those who are authorized and have that competency to do so. Back to you, Ma'am Elaine. Thank you so much.
Because eventually you will also, kasi there's some here who are asking if they can actually volunteer and be taught how to inject. Because eventually, magro-roll out naman if there are plans to have this certification for who's going to do the vaccination. Now, there's this one question here. I guess I have to address this to Dr. Arevalo. Supposedly, the national government entered into a tripartite agreement with the LGU and the private sector in the procurement of COVID vaccines. So does this mean that the vaccines will be available for commercial use? And would that be possible considering that all the vaccines for now will be under EUA?
I'm not so well versed on the vaccines being available in the market commercially as of now. But as I understood, wala pang magiging available na vaccine until such time that they have acquired a certificate of product registration. And this product, lahat naman ng produkto habang wala pang CPR, just like the vaccine, which is to complete the phase 4, then hindi pa siya magiging available in the market. So this is still be operating on the basis of the emergency use authorization, which will be granted by the FDA to the Department of Health. And of course, ito ay meron ng mga nag-apply, nagsipag-apply at made public naman na yung mga bakuna o yung mga manufacturers na nag-apply na. But definitely, there would be no vaccines commercially available at this point in time kasi ginagamit ito for emergency use.
Okay. So far for now, it will not be commercially available.
Yes po.
Okay.
So if the local government of the private sector will be procuring, then it would be on a tripartite agreement wherein they will be procuring via the Department of Health. Hindi po sila pwedeng bumili na that going through that agreement with the Department of Health.
So the next question here, I'll address to Dr. Alora, who's the infectious disease expert. What percentage of the population should the government, here actually it states here that the government intend to vaccinate, but let's ask the opinion of Dr. Alora, how many should we vaccinate in the first place?
They have computed how many would be necessary for herd immunity, depending on the transmissibility of the vaccine. Yung mga are not ganon. That will change because it depends again if the variant comes in, mas magiging transmissible na naman yan, tataas na naman natin. So we cannot answer that until the actual time is ready.
Okay, but so far, Dr. Arevalo, you mentioned in your list na for the priority around how many again? Sorry.
25 million for the priority group B and 10 million for priority group B. That includes teachers and other workers, essential workers. And the rest of the population would be under priority C. the whole of the nation na ito. So, of
Okay.
course, excluding those who have not been like the below 16 years old or below 18 years old, wala pa tayong recommendation from the scientific experts na magpapakuna tayo for this segment of the population.
So most likely, family household members of health workers would be under Group C pa rin, no?
Yes, the whole of the population. Kasi meron tayong categorization because the vaccine will not be delivered one time, big time. So the vaccine would be in tranches or depending on the pace. Kasi di ba yung pag-manufacture din sa kanya, dapat freshly manufactured din siya. So when we get to that agreement, when we get to procure, then there's a lead time for them to freshly manufacture the commodities and that this will be delivered to us and then in tranches. So that we have the priority population so that if limited supply will be coming in, then we get to have the health workers first as prioritized based on the guiding principles.
And for Dr. Alora, what's the youngest age group who can be vaccinated?
Yeah, they've not established that yet. That's why most of the studies have been on adults. That's why there's no recommendation for children. So youngest would be 18 years old or
moment.
maybe 17. Yeah.
Yeah. Then for Professor Karandang, what if there's not enough vaccine for all the priority groups? What do we do then?
We have to wait.
And pray.
Ganun lang. We have to wait. We have to watch. We have to maintain our apat dapat. Air circulation, good ventilation, short interaction time. We need to maintain physical distancing. All of those non-pharmaceutical interventions need to be maintained. But let me just share with you, Dr. Elaine, if you will allow me. I also added that aside from maintaining the apat dapat tama din. Ano ba yung dapat tama ko sinabi, no? Tama, ligtas, epektibo, mabisa at sulit ang presyo ng piniling bakuna ng pamahalaan. Dumaan sa tamang proseso, aprobado at rehistrado ng FDA, sumunod sa mga batas at tinakdang prioridad. Nasuri ng tama ang mga bakuna ng mga tunay at tamang eksperto sa kalusugan, pagbabakuna at epidemiolohiya at lubusang iginalang ang karapatan ng mamayang Pilipino sa kalusugan para sa lahat at sa dekalidad at tamang serbisyong pangkalusugan. Kung sumunod tayo sa apat dapat at natupad din yung dapat tama, maaari ko nang sabihin sa iyo, Dr. Elaine, love kita, halina at tayo ay magpabakuna. That was my tagline in the past 2 town halls because we need to watch the process. We need to make sure that the right vaccine is chosen. Let me be honest, it's very frustrating because we all know that some groups have gone ahead. So where is ethics and equity there? Yun ang tanong natin. Pababayaan pa ba natin na maulit yun ulit? Nasa pagbabantay po ng taong bayan yan. Ang tawag ko po sa ating bakunang padating ay bakuna ng taong bayan. Hindi bakuna ng presidente, ng governor, ng mayor, ng presidente ng kumpanya. Yan ay bakuna ng taong bayan. Hindi po yan makakadating dito kung hindi po aangkat ng ating gobyerno at sila po ang mamamahagi. So tayo po ay dapat magbantay sa proseso din po. At mag-ingay po tayo kung hindi po natutupad yung pinangako ng gobyernong gawin natin. Hindi po madali ang aming gawain dahil marami hong ingay na nangyayari. Thank you.
Regarding that po, Ma'am Nina, yun nga, no, how do we convince? So again, with what happened to the Vaxia issue, so there's a mistrust concerning vaccination in the general population and even among doctors, as what you've shown us a while ago. How does DOH plan to launch? I know you're part of NITAG, which is a group on the health promotion. How do we convince the people to bring back their trust for these vaccines?
Okay, let me just clarify. The National Immunization Technical Advisory Group is advisory. We don't work for the Department of Health. So we also maintain our independence, and DOH through Dr. Nap and his team provide secretariat support. So that's important to clarify. When people ask me that question, and you're not the first one to ask, so what do we do? I bring them back to the story of how vaccines have saved millions of lives throughout the decades. So let us go back to what vaccines have brought to us in terms of lesser disease and lesser morbidity. And we should, again, be mindful that the marginalized groups are also paid attention to, so that we don't have a repeat again of the misinformation, disinformation, the uninformed and underinformed views, which have destroyed our vaccination campaign. By the way, even before Dengvaxia, our national immunization rate for children specifically was a low of 61% already. So with or without Dengvaxia, we already had a problem. And I think the role of the healthcare workers is primary for this. We need to be good models, like Dr. Alora was saying, and walk our talk. If we don't have ourselves vaccinated, how can we also convince others to follow suit? So let's go back to the history of what vaccines have been able to do to save lives and also reduce morbidity. Let us go back also to the fact that we also have our roles as educators, as role models for other people to also be convinced. The voice of a healthcare worker, especially a physician, is so powerful to convince individuals, families, and communities. Salamat.
Okay, thank you. Actually, we still have a lot of questions here, but I do hope if it's okay with you, you can look at the questions, and if in case I'm not able to finish them and it's now almost 8 p.m., any last words of advice for our doctors here from Dr. Alora?
Well, don't lose hope. We're going to get there. Just pray and wait.
Okay. So, Professor Karandang?
Let us be patient, like Dr. Alora said, but let us also be vigilant. Let us not be afraid to speak up and stand up for those who have lost their voice. Amidst the pandemic, many more people have lost their voice. So let us stand up for those who have lost their voice, and remember that health is a human right. Salamat.
And Dr. Arevalo?
Yes, the pandemic is unprecedented globally, and of course, in the Philippines, no, we have not experienced such a gargantuan circumstance that we have to respond to. So we are enjoining everybody that by working together, both in the public and the private sector, having that whole of nation, whole of government, and whole of society approach, we will be able to achieve the goals of reducing morbidity and mortality as brought about by COVID-19, and we hope to live at least near to normal lives while we provide interventions, not only the vaccines, but still observing strictly the non-pharmaceutical interventions that we practice before, and it should also not be forgotten even if we have the vaccines already. So kung tayo ay sama-sama, lahat natin magagawa ang gusto nating mangyari for us to be able to at least be back to a near normal circumstance. Maraming salamat.
So thank you again, Dr. Alora, Professor Karandang,
Welcome.
Dr. Arevalo. Again, for our listeners and viewers, we're sorry we cannot accommodate all of your questions, but don't worry. I'm sure we will have additional health forum regarding the vaccines themselves. Actually, some of your questions pertain to the actual vaccine, which is not exactly covered with this by this health forum, but I'm sure in the future we will come up with more, not only for our colleagues, but more so also for our patients and the public in general. Again, thank you, everyone. And thank you also for the Philippine College of Physicians and the Philippine Society of Microbiology and Infectious Disease for your alliance in terms of educating us, doctors, together eventually with the public. And we do, yes, we do.
Thank you.
Yes, so we do hope to see you all in our next forum. So have a pleasant night, everyone. Thank you.